Okay. Hello everyone. In this particular topic, we're going to go through some diseases which are related in hematology. Okay, I'm Yuan. Similarly to the physiology of the blood, in a way that in hematology, we'll mainly be focusing on the diseases which are related to the red blood cells, i.e., the hemoglobin, because the others are sort of being covered elsewhere, like leukemia will be covered in the oncology section, right? And the blood clotting one, the excessive blood clot, that one we didn't, you're not going to go through very detailed actually, right? This is a poster, particularly by I think it was one from one of the organizations. So in conjunction with the Blood Disease Month, which is in September every year. So as you can see here, they talk about as anemia that we'll be mainly focusing about. The general one is anemia, but there's a lot of subtypes. So this is the one that we're going to go through. Anemia in general has similar same symptoms in a way, whereby it's weakness, shortness of breath, and things like fatigue, fast, irregular heartbeat, and things like that, because it's in a way it's characterized by a reduction or low hemoglobin count. Right, there's different subtypes as mentioned that we'll go through. Some of it are actually preventable through more balanced diet, like for example, sufficient dietary intake of iron from meat sources, or if not, then from supplementation or vitamin B12, and also folic acid waste. Right, so these are the things that we are going to go through. So next, when we look at the different parameters that is being measured in the blood test, which are related to RBC. So you can see that there's hematocrit, so it can be elevated. This is polycythemia. Depressed is anemia, so you can see in anemia depressed hematocrit, to reduce hemoglobin concentration, and also reduce RBC count. So meaning in any it's reduction in the count of it, but some of it subtypes of anemia are actually linked to other elevated in, for example, mean corpuscular volume (MCV), which can be macro or microcytic, and also hyperchromic or hypochromic in the mean corpuscular hemoglobin concentration. Right, so you would need to know the characteristics of each of the types of the anemia, right? Because that would link in more details into their own specific features. Okay, next. So this is actually a slide which is actually from the Anatomy and Physiology book, which actually captures a very brief summary on all the different subtypes of anemia. So, for example, the first one, which is the most popular one, is the iron deficiency anemia, right? So it's more common in women because, we have menstrual blood loss, and during pregnancy when the baby needs more of it for its own blood supply development and things like that. Okay, so there's also other types of anemia like megaloblastic anemia, which is a reduction insufficient in vitamin B12 or folic acid. There's also pernicious anemia, which is linked to the vitamin B12 insufficiency due to the reduction in the intrinsic factor in the stomach. Okay, which reduces the absorption of B12. And there's also hemorrhagic anemia. So obviously from the name, there's too much blood loss, and therefore lead to anemia. There's also hemolytic anemia, which is slightly linked to one of it is what we've seen in the newborn ones. But there's also other different causes that can lead to it. And there's also some which are inheritable, like thalassemia, which you've probably heard it before. Right, and there's also aplastic anemia, which can be due to exposure of surroundings or certain medications like toxin and things like that, which affects the synthesis of red blood cells. Next, there's also a very so those just now we'll actually discuss more in detail later on in different slides. But there's one which is here, which is called sickle cell disease or sickle cell anemia, which is pretty popular. This one is the information is mainly just over here, so we'll just go through very briefly. So what happens is that when you look at the size or the shape of it, you can see the sickle one is this one, the long one. So obviously the surface area all is wrong. So therefore, the oxygen transport capacity of it is not so high, right, or efficient. So signs and symptoms. So what happens that when it's sickle, so they break down prematurely. As you can see, it's all here. So remember, it's supposed to last for 3 months, but obviously this one is just within a month because it's 10 to 20 days. So again, lead to typical symptoms of anemia. So which can also lead to jaundice and things like that, and it also can form blood clumping, right? So obviously, the whole system, the whole body system basically goes upside down. Okay, right? Because they can have painful episodes as well because of the clumping and blockages and insufficiency in oxygen um, into the different organs. So therefore, it's something that you have to consider in the pain management as well. Okay, so this is an inheritable one. So again, it's a little bit like thalassemia in terms of its inheritance. So you need two of the recessive, and then it comes together, and then it becomes a full-blown um, sickle cell anemia disease. If not, it's just a carrier as usual, right? So and they realize that if it's carrier, they are more resistant to malaria. So certain parts of the world actually has a higher one because due to a selective survival, right? So because of the pain, there's analgesic to reduce the pain. So and then we have to give blood transfusion to them, right? So therefore, and it's also good to note that when they are born, in a way, they normally have normal fetal hemoglobin, right, predominantly. But later on, when it goes, and the baby grows big, obviously they couldn't make proper one, so therefore the manifestation of the disease start to kick in better. Okay, so next we'll look into, there's also hemophilia, right? So again, it's a more inheritable disease, like. So this is it's famous because of it affects one of the queen, which is the royal kingdom, which is Queen Victoria, sorry. So therefore, so again, it can be so it's something that they can't control the bleeding very well. So they got deficiency in blood clotting. So as mentioned with the blood clotting ones, so sometimes it can be spontaneous bleeding, and also which is something that they have to. So it can be a specific absence of or reduction in certain types of blood clotting factors. So whichever is not enough, so they have basically just have to top up that particular one. Okay, so there's a lot of genetic testing and things like that to determine as well. Okay, so there's a few key concepts that I just got it from the pharmacotherapy books. So you can see this is the general key concept of anemia. So it's quite similar to the one which I mentioned earlier on, but there's a little bit more information on the therapy. So you can go through them very briefly as a short revision if it's helpful. Okay, so but for the moment we'll go through the more specific ones. So as you can see here, there's a different classification system. Remember just now we talked about the different morphology. So you've got macrocytic ones, it can be megaloblastic, or it can be microcytic, hypochromic, so these are the iron deficiency, sickle cell, thalassemia. Some are normocytic, so it doesn't affect the morphology, right? So you can see, so the vitamin deficiency one is at the top, right? So etiology, i.e. is the cause, so it can be dietary based, as mentioned over here. And it can be also due to some other impaired bone marrow function, hemorrhagic, pathophysiology. So there can be some other more rare causes, right? Like chronic renal disease, because it affects the hemopoietin release. Okay, next we can have a look at the general about anemia. So you can see the symptoms as mentioned just now: fatigue, weakness, pale, right? Headache, shortness of breath, chest pain because in a way there's not insufficient blood flow, so irregular heartbeat, dizziness. So presentation, so this is over here, so you can see that it can be a bit of tachycardia. So basically, you just have to order the lab test and then to measure the levels to see which one goes down and up to have a proper diagnosis about it. Okay, so this is a chart that covers everything, I think. So from MCV, so on the parameters, so if it's high, then what can it be, right? So you check the vitamin level, reduce folate level, then you know what is deficiency, right? So you can do certain tests, and again, you can go through the chart to know where is everything. Okay, so this is the overall chart. So for example, if you look at aplastic anemia, which is over here, so basically it's normal. So you check other parameters like reticulocyte count, right? So it's low. So look at the what WBC and platelets, they're also low, so it can be aplastic anemia or leukemia, right? So yes, so some it can affect multiple because aplastic anemia is something that is sort of like being damaged or being exposed to certain toxins, right? So the effect is more general rather than a very specific one to a certain type of blood cell. Right, so when we look through over here, like for example, iron deficiency anemia is over here because MCV is low, serum ferritin is low, so there's iron deficiency over here. So some we can look at the other parameters, so like thalassemia ones that's over here as well. And there's pernicious anemia, which is due to a reduction in intrinsic factors, so this is where it is. Okay, dokie, let's move on. Okay, so let's go through the most common type of anemia, which is iron deficiency, as mentioned just now. So there's some more recent guidelines, so I just put it over here. So the points over here actually the highlights or the notes, the important notes or suggestions by the guidelines. So I just put it down here. So it's the major cause. So it can be caused a wide range of GI pathologies, including cancer. So if it happens randomly out of the blue, so they probably just do an overall body checkup to rule out any other cause, because obviously if it's in cancer, or there could be some slow or chronic internal bleeding, so therefore that causes iron deficiency anemia because there's continuous losing of blood. Okay, so so you can see that anemia, the general definition, they look at the hemoglobin concentration, so below the lower limit. So so we try to get so you have to top up with the iron supplement in a way. So you can see they can measure certain like serum ferritin and things like that. But normally, if it's woman, if tired and things like, we'll just not recommend in a way iron supplements, right? Obviously, if it's better that if she does the person or the customer did some blood test first, but if not, it's still quite safe to recommend iron supplements, but let's see whether if he or she feels better or more energetic after that, right? But bear in mind, iron supplements, it actually stains the stool into a black color. So yeah, sometimes it gives people like a false shock. Like, oh my god, is it bleeding? So this is one part of iron supplement. If it's a high dose, it actually causes constipation as well. But if it's a supplement, if it's not a very severe one, you can actually recommend to take it alternate days and things like that. So it's not something, because it's more like a supplement base. If you use it as a tablet, so it's more like to top up what is missing from normal diet in a way. So it's more flexible in a way. If it's not the very severe ones, of course, what I'm referring to is the general ones, like for example in pregnancy, in breastfeeding, or women in general. Okay, so but obviously if the lady is postmenopausal and things which have symptoms like that, it's something they have to consider lah, or male, to have more considerations. Okay, like the GI one, which is mentioned in the guideline. So as you can see here, these are the charts from the guideline. So you can see that if it's so you have to have some background check. So serum ferritin is the best indicator. So in the end, if it's all okay, then you just go through the normal management. If not, then you have to consider as other sources, right? So again, you can see whether it is hypochromic or microcytic. Okay, so if it's suspected, so again, you can top up with iron replacement therapy. Right, so if after that, if it's still not so good, so again, you have to double check the GI abnormalities, right? So if not, then so you might need to consider long term if it's a consistent issue. Okay, so we go on to the next chart. Okay, so again, if you want to read through the details on the explanation, you can actually go through the guidelines. So I actually put it all in the folder so you can dig it out from there. So as you can see, some have very extreme symptomatic anemia. So this is the one that we probably have to treat them a little bit better. So obviously the first way in a way is we try to give it as oral form. If it's very, very severe or it's not responsive to the oral ones, you actually have to give it as an IV form. Right, so IV form is a bit more tricky in a way because obviously iron cannot be too high level in the body, so you actually need to calculate. Yeah, there's some calculations there, so you can go and find out. So the calculation is based on the person's value. So because overdosing of iron is actually it's actually dangerous or fatalish in a way. So it's not something that we're going to push too high in a way. Okay, so and bear in mind iron deficiency is it will take time to build up or to show symptoms in a way because you have to remember that our liver actually has a storeroom of it. So it's not something that like one day if you have not enough iron intake from the diet, then everything will go wrong. It actually takes some time. Okay, so when we go on, so again, just to double check again everything after especially the more severe ones, you have to do follow up lists, and then you monitor and taper the dose accordingly based on the situation. So, so this is again just a reminder there's pathological disorders associated with iron deficiency. So, as I say, it may be in case it's IBD, in case it's cancer, just in case it's hematuria, so i.e. blood from in the urine consistently. So, you have to just check through all the other possibilities, right? Because in a way, malignancy or cancer can occur anywhere. So, so there's also malabsorption symptoms in case there's H. pylori infection and things like that. So there's also chronic heart disease or chronic kidney disease, which could link to iron deficiency anemia. Okie dokie, so let's move on. Okay, so there's different types of iron preparation. So most of it is available over the counter for the tablet ones. So some of them is just pure ferrous tablets. So you can see there's ferrous sulfate, gluconate, fumarate. So these are the three main ones. Okay, sulfate, fumarate, gluconate. So what happens is that they're about the same in terms of the efficacy, right? Just a tab a day. So some of the preparation actually as a combination together with vitamin C or folic acid. So or some of them obviously it can be available as multivitamin, but so the iron is sort of hiding in there. So basically, yeah, any preparation will do. So some of them is higher dose. So again, depends on the situation. Okay, right. So and bear in mind the side effects that I talked about just now. So there could be some IV preparations as well. So you can see there's iron sucrose, iron dextran, and things like that. So all this again, that's the main thing is the dose has to be customized for the situation, for the condition exactly. Okay, so let's move on. So there's also some notes. So again, from the guideline just now, I'm sorry for the typing, it's so tiny, but I'm sure you got the PDF, so you can actually enlarge it to see it better. So, so again, this is it's quite similar to what I've mentioned earlier on. So some common special situations like those which are observed in CKD, right? So it's also common in heart failure, which is multifactorial. So sometimes if it's very severe CKD, again you have to. It's better because they'll be under specialist care anyway because it has to be tapered more carefully because you have to also taper the hematopoietin level as well. Okay, so it might be top up from there as well. So it's a more multi-angle management of the anemia. Okay, so this is what it is at the moment. So next, we'll also just as a recap on the food which are rich in iron, because remember when you give counseling on if the person were to take supplements of iron, if it's the mild one, is it necessary to take it long term? So it's also good to remind them that there's different food which are rich in iron, so they can sometimes take some of it. So a lot of it are from meat-based source, like from chicken, pork, egg, and things. If the person is a vegetarian, so you can take more spinach and broccoli and things like that. Okay, so next we'll move on to another disease, which is thalassemia. So in thalassemia here, I just want to point out about the different types of the what do you call the chain. Remember in the physiology, um, we already know that the red blood cells has two alpha chain and two beta chain. So what happens is that at birth, so the body would need to produce more beta chains, whereas in baby and also there will be some reserve on the gamma chain right over here. So so the body needs to produce more beta chain. So in thalassemia, so there'll be some difficulty in producing the appropriate beta chain. So therefore, as mentioned over here, for some cases it can be a total absence of it. Some will be a reduced level of the beta chain. So they'll therefore have an excess of the globin because they cannot form appropriate erythrocytes, because they need two components, obviously the heme and the globin, to work together. So on the chain, so it doesn't work properly, so there's extra of the alpha, because remember it needs alpha and beta to pair together. So if they cannot have enough beta, so the alpha is sort of like excessive around on the way, so it can cause membrane damage, so therefore it causes hemolysis. So, and obviously it's ineffective erythropoiesis as well, therefore leading to anemia. So over here, it's also so in the treatment, so you probably need blood transfusion most of the time, especially for the severe cases. So again, there'll be more excessive iron, which can lead to organ failure. So which is what we want to avoid. So there is some guidelines, recent guidelines as well, so they can refer to. So next, when we move on, so it actually tells you the different subtype in a way. So you can actually have the non-transfusion dependent ones and also the transfusion dependent ones. So obviously the outcome is not so good for the transfusion dependent one. It's actually not easy in a way because there's a lot of blood transfusion, consistent scheduled blood transfusion. That obviously blood transfusion leads to a lot of risks, like disease risk. And another thing is it's also there's lead to a lot of iron overload, so you have to take certain medication, so it has to be balanced out very carefully, and also it's not an easy disease to handle, right? So the life expectancy is not very high, so if they can survive until teenager or ish, it's considered quite an achievement, which is pretty sad actually. Right, so therefore that's the genetic testing come into place to actually prevent these diseases, so you can sort of select appropriately. Right, so when we look at it, so there's different types of the severity, right? So you can see some of the hemoglobin levels are really, really low, right? So some are still within the normal-ish. So when they're normal-ish, so they'll probably be the non-transfusion dependent ones. So these are the different diagnostic measures. So bear in mind there's also the genetic ones as well for better diagnosis and to know the severity of the disease. So next, so there's some criteria to initiate the blood transfusion therapy. So there's certain, so you can see, obviously you need to be confirmed that yes, it is thalassemia, unfortunately. So the level it's low and more than 2 weeks apart, so it's consistently a lower one. And poor growth because there's not enough red blood cells or oxygen for the organ to grow properly, right, and to develop properly, and certain different complications, significant symptoms. So, and there's also calculations involved in the amount of blood volume that is required as well. So there's a very tacky, what do you call it, calculation that you need to do, which is in the guideline, but I didn't include in the slide. Right, so bear in mind they also need iron chelation therapy. right? And there's also different. You may need stem cell transplantation or right things that. So it's tricky. It's tricky, right? So next. Okay, so basically for this slide, we're going to look through the mechanism for toxic effects of iron overload. So iron overload is probably one of the main cause of fatality in people with thalassemia because they have to go through multiple blood transfusion. So, and they have to really taper the concentration of iron in the body. So basically, iron overload literally causes like a very stressful event to the cell, so like through ROS, through infection, neoplasia, different things that eventually leads to cell death. So if it actually do happen, it's actually a very sudden death, actually, to be frank. So it's something nasty. It's not easy to manage this disease, right? So if we move on, so there's different types of chelator to prevent the iron overload from happening. So as you can see here, there's three main medications that you can use. So it's the desferoxamine, um, deferasirox, and deferiprone. So you can see the half-life of the medication is different, so it depends on the scenario that you need to use it, right? So if it's a very fast one that you need to kick in, so then obviously the IV one would be the fast one to be used in the hospital, right? So the others you can take it as an oral medication as well, right? So if we move on, so these are the pharmacological features of it. So next, so as you can see here, the metabolism route. So recommended dose, so again you have to calculate accordingly based on the weight of the person. So here there's certain side effects as well, the main ones. So basically GI related and so on and so forth. So it's something, so again, because of the blood transfusion, they have to be in a hospital, of course. So there'll be quite frequent hospital visits and to get blood tests and all to make sure the dose and all is at the correct level. Okay, so next we'll go on to the cardiovascular disease, so the risk of cardiovascular disease in thalassemia as well. So basically, because there's hemolysis, right, which can cause anemia. So it's a flip-flop between anemia and transfusion. So you can get a high output state because of the transfusion as a shock. So it's actually higher risk to get vascular disorders, and again it goes back again. So it's basically a vicious loop. So which can lead to arrhythmia, heart failure, and so on. So it's again a nasty one to get. Another part is about cardiomyopathy as well. So what happens is again linked to iron overload as mentioned over here. So transferrin saturation, because there's too much of transferrin. So which can affect the cardiomyocyte L calcium channels eventually. So iron overload, oxidative stress, and again myocardial dysfunction. So again lead to the risk of high sudden death. So so they can be at a shorter size as well because of it probably don't have enough blood supply sometimes, so and things like that. So it's not easy basically. All right, so it can have all sorts of hormonal related issues as well, right? So and also has higher risk of diabetes. So you can see it's so due to one disease, in a way, it comes together with a lot of other issues. So it's not easy to manage. So basically, they have to manage all the different issues together as a whole. Okay, so that's all for the first part of the class. So move on. I'll see you in the next one. Okay, see ya.